Good afternoon, ladies and gentlemen. Thanks for joining us this afternoon at this educational exercise. My name is Tom Marwick. I'm the director of Baker IDl. I've been in the role since January of this year. To begin with, I'd like to welcome you to country, to acknowledge this event is being held on the traditional lands of the Wurundjeri people, and to pay my respect to the elders, both past and present. This series of presentations which the Institute is running this year is a very important part of our task, I believe. Clearly, this Institute is about reducing the burden of disease from cardiovascular disease and diabetes and obesity. But in addition to research, we think that scientific training is an important part of what we do, and we also do our work in conjunction with support from the community. And part of our way of recognizing that is to help inform you about things that we think are important. And although there have been huge inroads into the burden of cardiovascular disease in the last probably 30 or 40 years, this problem has not been solved. It remains the single major cause of death in Australia. And in fact, the achievements that we've had are beginning to plateau out. In 2011, for the first time, the reduction of cardiovascular disease started to plateau in the US, and I think we are going to see the same thing in Australia. And we know that there are some groups who will probably have a shorter life expectancy than their parents that are based on the development of obesity and diabetes in the community. So a serious problem, and I'm delighted that you're interested to come along and also for your support. This institute is really based on 5 pillars. What you're hearing tonight is about an area that we called atherothrombosis, the topic of damage to the blood vessels and the blood clots that can form as a consequence. We're also interested in cardiovascular diseases associated with aging, so that's heart failure and atrial fibrillation in particular. Exercise and prevention has been a theme at this institute for many years, and we're still very active in that area. And then our other 2 themes are related to diabetes, clinical diabetes and obesity, and diabetes complications. So this institute really looks at the things that are driving the cardiovascular disease epidemic and trying to solve the cardiovascular problems. As I mentioned, this Health Matters series will constitute 5 presentations in the course of the year. This is the 3rd. We had a couple of very successful earlier sessions on assessing risk of developing cardiovascular disease and about diet. Now today we're going to talk about recognizing the signs of heart attack, and this is a very important topic. It can be really a matter of life and death. So the way that we will proceed here is that Professor Karlheinz Peter, who's a colleague of mine, will be talking about the things that you should know about this process, and then Sue and Shekhar, a couple of Karlheinz's patients, have been very kind to give their time to give their experiences, and then we'll have an opportunity for some questions and answers. And can I just say, when we get to the questions and answers, we are really keen for you to engage. I can tell you personally, and I'm sure Karlheinz has this experience, it's very difficult to give personal medical advice, particularly in a lecture theatre. So if you have personal questions, if you can sort of generalize from them, it will make life easier all around. We will talk about that later on. So Karlheinz, please, over to you.
Thanks very much for coming this evening. So, heart attack is for me a matter that is close to my heart for several reasons. It actually started my medical career, so a heart attack really started it. I was sitting with my father when I was a teenager. Pierce kind of smoked heavily, and so he told me that he has some funny feeling in his chest, but I shouldn't really mind about it. And then it got worse and worse, and after a while I convinced him that we should actually go to the hospital. And he still wanted to drive with his car, and I managed to call a taxi, and then we went to the hospital. He actually had a heart attack. And as a teenager, being in school, I've witnessed for the first time how medicine can work well and help people. And so I decided this is an area I would like to work in, to make it to my profession. And then I studied, and actually later on my father had 2 further heart attacks, and I treated them myself, so I stented him twice. And it has actually a nice story together with the Baker as well. A few years ago, Professor Gary Jennings, who was the previous director here at the Baker, he thought about offering me a position, but he wanted to check out whether I'm really as good as it looked on the paper. So he came and visited me at the University of Freiburg, and we were sitting 5 minutes together, and then I got a call from the emergency department saying, oh, my father is again with a heart attack. I should come and treat him. And I was there and stuck with Gary Jennings, and I thought, okay, I can't leave him alone, so I take him with me. And so he witnessed how I treated my father at the end, and so I think that was one of the reasons why he offered me a job at the Baker. So when you look at this picture, you more or less see the heart as we describe it with all the anatomical areas. Now, the heart for many is the area where the soul resides. For others, it's just a muscle that is very efficient. And when you take the second view, you still have to be very fascinated by the heart when you realize how efficient the heart works. So it contracts regularly 24/7. So when you calculate with 60 beats per minute, it's 100,000 times a day, and you can then calculate how often a heart beats over an average age of 80 years. Also, when you look at the amount of fluid, of blood the heart pumps, it's really enormous, 3 to 5 liters per minute, around 7,000 liters per day. You can calculate how many liters a heart pumps over a lifespan. It's quite variable in demand, so it can change the rate, for example, from 40 beats per minute up to 200, 240 beats per minute. The pre and after load can be changed. For example, the blood pressure, you can survive with a blood pressure of 80 systolic, and you can go up to 250 or even higher. And it supplies, and this is really a number that is unbelievable, when you line up all the vessels that are supplied by the heart, it's around 100,000 kilometers of small vessels that the heart supplies. So it's an enormous organ, and it's really fascinating. And the longer we as cardiologists work with the heart, the more fascinated we get from this organ. So the heart itself needs blood supply, and the arteries that do this are called coronary arteries. And when you see this picture, this coronary, corona is the Latin word for crown. So these arteries crown kind of the heart. So you can see here the red ones. This is a coronary artery, and this here. And in this schematic drawing, it's a bit easier to recognize where they come from. So this is the right coronary artery. It comes from the aorta. The left coronary artery with the main stem here, and then it divides into 2 branches. This left anterior descending coronary artery and the circumflex artery. So this is where all our life depends on, that we have good perfusion through these arteries. This is how we describe it in the cath lab. So we look at the main arteries and all the small branches. And this is how it looks like when you actually look at the human heart. So this heart was prepared in a way that the coronary arteries were filled with a red plastic material, and then the heart itself was digested. And it just shows you how many small vessels there are that supply the heart. And you can imagine if you block one of these arteries, there's a big effect because all the rest of the tissue here is not perfused. Now what we do in the angiogram, we do pretty much the same as here with this plastic material. We inject contrast reagents into the coronary arteries, and then we show them in the X-ray film. Why are we interested in the coronary arteries? And the reason for this is actually quite drastic, because most of us will develop disease in our coronary arteries, and around 1/3 of us will be killed by our coronary arteries. So it's a really major concern. And when you look at this disease that is behind this, then you understand why we have such a big problem. So the disease that underlies these problems is called atherosclerosis. Atheroma stands for accumulation of necrotic material. Sclerosis describes the hardening of arteries, and typically these kind of changes are localized, and so they form plaques, plaque-like structures, and we call these atherosclerotic plaques. And these are two examples. This is the carotid artery of a patient here, and you can see here this necrotic material. It's in form of a plaque inside of the coronary of the carotid artery. And this here is the coronary artery. Again, you can see this atheroma here, a lot of necrotic material and blood inside. And here you get a feeling of this porcelain-like structure, how hard this vessel is. It's not flexible as it is, for example, here. It's really a stiff vessel that causes a lot of problems. Now, the scope of atherosclerosis is immense. These are Australian numbers from 2002, and you can see that nearly 40% of all deaths are caused by cardiovascular diseases. It's still pretty much the same numbers. And when you look at recent numbers published from the WHO, you see that ischemic heart disease, which is nothing else than coronary artery disease, is the biggest cause of death, and then directly behind is stroke, and stroke in most cases is also caused by atherosclerosis. And then we have infections, and then much later on we have various cancers. So it's clear when you compare this with the cause of death, it's really atherosclerosis that drives our life expectancy. Now, atherosclerosis is not a disease that is new with our lifestyle associated. It's an old disease. It's probably around as long as humans are around. So these are pictures, CT pictures from mummies. The right is an Egyptian mummy. This is a Latin American mummy. So this is 5,000 years old. This is around 3,000 years old. And what you can see here are the necrosis, atherosclerosis, calcification of the right coronary artery. You can see the whole right coronary artery filled up with this material, and here is the right coronary artery and the left as well. So this is really an old disease that is around in thousands of years. So now you might think, oh, I have never had any chest pain, so I probably don't have atherosclerosis in my coronary arteries. But the fact is actually quite drastic when you look at the numbers. So this is a study that was done in autopsy cases of people who died in car accidents. So they didn't have any heart attack, and the pathologist looked whether they have plaques sitting in their coronary arteries. And you can see here, even teenagers already have around 30% of them have plaques sitting in their coronary arteries. When you go to the 26 to 39 years old, around half of them have. If you go to the older population, probably 80 to 90% of us will have coronary plaques. So it's really a disease that concerns everybody. So what is the reason for atherosclerosis? Nowadays we know that it's an inflammatory disease, but we have to admit that still, despite all the research, we don't really understand atherosclerosis very well. And Baker is one of the big places in Australia where we focus on understanding this disease and potentially from learning how it works, also would at some stage be able to develop medications against atherosclerosis. Now, why is it an inflammatory disease? And there are several arguments, and I have just shown a few of them. When you look in these plaques, you can see that there's a massive accumulation of inflammatory cells. We can see that markers of inflammation are up when we take blood tests, for example. The C-reactive protein is increased as a marker, a general marker of inflammation. We know that infections play a role, and in the 90s, after the Australians in Perth got the Nobel Prize for detecting that the peptic ulcer is caused by an infection, people thought, oh, maybe atherosclerosis is an infectious disease, so there might be a bacteria or viruses that cause this, and there were several trials ongoing checking whether antibiotic treatment might be able to get rid of atherosclerosis, but the outcome was very disappointing. So atherosclerosis is somehow associated with infections, but we can't really pinpoint a certain bacteria or a certain virus that would cause it. We know that there are a lot of activities of digestive enzymes, so we can even measure the temperature of an atherosclerotic plaque. If you go in with a thermometer, it's around 1 degree Celsius hotter than the surrounding. And then the last argument is an important one. When we have patients who have chronic inflammatory diseases like arthritis or other autoimmune diseases, we know that they have an increased risk of developing atherosclerotic plaques. Now, how does atherosclerosis look like? When you go into these vessels and do histology, you can see that early on you have inflammatory markers on the surface of the cells that line these vessels. And when you look at advanced atherosclerotic plaques, there's a lot of staining here, so a lot of surface markers show up. And then over time, white blood cells adhere at the lining of these vessels. They go into the vessel wall, and this can be shown here directly in an electron microscopy. You see these white blood cells. These are the cells that line the vessels, and they attach and squeeze themselves into the vessel wall. This is how it looks after a while. So you have necrotic material, a lot of lipid sitting around, and you have lots of cells adhering and continuing this drive of inflammation over the years. So this is probably a process that takes place over decades. So developing atherosclerosis typically starts as a teenager and it manifests typically in the 40s and 50s. So now you can develop atherosclerosis in two different directions. One is that you develop stable atherosclerosis, and the other that you develop unstable atherosclerosis. So this is actually something that is quite nice for cardiologists, because when the plaque progresses, it grows and it finally causes a narrowing of the lumen. When you do exercise, you feel chest pain. When you stop the exercise, the chest pain is gone. You go to the doctor, he does an angiogram, and he can stent you, and so that's an optimal outcome for a cardiologist. Unfortunately, this is rather the rare situation. So when you look at the plaques here, so this is an example of such a stable plaque. It's a big plaque, so it causes a narrowing already. So it causes chest pain when you do exercise, but it's quite stable. Now when you look at the other direction, so this develops into unstable rupture-prone atherosclerotic plaques. Finally it ruptures, it causes a heart attack, a myocardial infarction, the patient dies, or he develops heart failure. And this is the most often cause of things that we see. Now this is how an unstable plaque looks like. You have a big necrotic core, there's a thin cap on top with a lot of inflammation ongoing. So you get the feeling that this easily ruptures, and there's a lot of enzyme activity. You can really stain this, and so it's really hot in this area. And this is what happens then. The plaque ruptures, you have a lot of platelets adhering, then you have a clot development, and the vessel is blocked, and you have a heart attack. And this is an example of a patient who died of a heart attack. So this was the lumen where the blood flow was. Here was the necrotic area with a lot of lipid, and this was the cap that ruptured, that broke, and this is a platelet aggregate that you can see here. Very often these aggregates kind of dissolve, and they develop as an embolus, and then they get stuck in the periphery of the heart, as shown here. So this is the vessel, this is the heart tissue, and that's the blockage through this embolus. Now when you look at the numbers of heart attacks, of myocardial infarction, it's still in a way that around 20% of all deaths are caused by heart attack. It's around 26,000 deaths per year in Australia. We know that 400,000 patients have coronary artery disease, so this is kind of registered. We estimate that around 4 million of the 22 or 23 millions of Australians have coronary artery disease. It's also a leading cause of disability. Very often we forget this. If patients had a heart attack, they don't make it early enough to the hospital, they develop heart failure, they develop shortness of breath, and this is a severe disability that kind of restricts life quality for patients. In 2020, the estimate is that it will be a worldwide leading problem because countries like India or China pick up on our life standards, on our bad food and low level of exercise, and they will develop a lot of coronary artery problems. One of the problems that we face also here in Australia, especially with the long distances, is that only around 1/5 of all patients really make it in due time to the hospital. So this is the reason why we always try to tell people, when you have the feeling you have a heart attack, you have to rush to the hospital. If you don't make it within an hour or 1.5 hours, most of your myocardial tissue is already gone. So now what are the risk factors? You can separate the risks in 2 different types. One type that you can't change and another type that you can change. So you can't change your age. Age is a major risk factor. The older you get, the higher is the risk that you develop a heart attack. Gender, up to a few years ago we would have said, oh, it's probably mainly a male disease, but nowadays we know that males are having heart attacks early on, but then in the later years females pick up. So when you look at 80 or 85 years old patients, then it's probably quite equal the numbers of heart attacks between men and women. The ethnic background, there's clearly a genetic component of heart disease. For example, people from the Indian subcontinent, they have a higher risk to developing heart attacks, and unfortunately also Aboriginal people and Torres Strait Islanders have a higher risk. It's not entirely clear whether this is purely genetics or whether it's also associated by the lifestyle. And then one of the biggest things that you can't change is really the family history. If you have siblings or if your parents had heart attacks at a very early age, then your risk to develop a heart attack is also higher. Now, what can you change to reduce the risk to develop a heart attack? Number one is really smoking. If you stop smoking, then you reduce the risk of a heart attack. And this can be seen in all the statistics when we look at the numbers of people smoking and the number of heart attacks. When we reduce this is really nicely documented in the US, where they did this early on with very aggressive campaigns, then you can reduce the number of heart attacks. High cholesterol, this is mainly an issue that we deal with tablets nowadays, with statins. High blood pressure, it's very important to have a reasonable blood pressure control. Diabetes, an optimal sugar control of your diabetes. Then this is an important point that people who are inactive, who don't move, have a really high risk of heart attack. Then obese people, and this is something that Professor Marwick mentioned, the overweight that we see more and more probably antagonizes all the medical benefits that we have achieved over the last decades, because this is a major risk factor. And then one part of our unhealthy lifestyle, so to say, is our unhealthy diet, and this is certainly contributing to heart attacks as well. Now, the concept, when you see this, you would think, oh, we should actually be able to identify those plaques that are dangerous, those that are kind of prone to rupture, and to develop imaging technologies to kind of make clear who needs treatment, who doesn't need treatment. It's kind of a holy grail of cardiology, and we do quite a bit of research here at the Baker, and I just wanted to show you 3 or 4 areas where we work on, where we try to identify those patients at risk. And when you look at the background that we have in the medical field, you wonder, why can we not achieve this? Why can we not tell when a patient comes to the hospital, you are at risk to develop a heart attack, or you can go home without any problem? When you look at the various technologies that we have around, then the first thing that comes to mind are blood tests. And unfortunately, we have to admit we don't have any blood tests that would tell us whether you are at risk of developing a heart attack or not. Then imaging. So when we look at ultrasound, everybody knows the echocardiogram. The problem is that ultrasound doesn't have the resolution. We can't look at these small coronary arteries, and we can't detect whether there is a dangerous plaque or not. We tried to do this with new catheter technologies when we went into the coronary arteries with the catheter. But again, we can only see whether there is some plaque buildup, but we can't tell whether there is inflammation, whether there is a dangerous situation. And even the top machines that we have, MRIs or a CT, is not really able to do this. And Professor Marwick, I will show one example of this. He focuses on the CT and tries to develop technologies to use that technology to detect patients at risk. Now, you might wonder, the angiogram, this must be the number one thing in cardiology, because every patient tells you they had an angiogram and then they get out and the doctor tells them everything is fine or there are some problems. Now, when you look at the angiogram, there's a big issue, because what we do with an angiogram, we just see whether there's a lumen, whether there's a narrowing of the lumen. But the problem is that plaques build up in the wall. You can have a massive inflamed plaque, as in this example, and when you look at the diameter of these vessels, it wouldn't even show up in the angiogram. So that method is not useful at all to tell somebody whether he is at risk or not. So it's not a suitable technology, and a normal angiogram does not exclude a heart attack in the near future. And we had patients, for example, where we did an angiogram, and the next day the patient is discharged, and we tell him everything is fine, you don't have to be worried. The next day he comes in and has a massive heart attack, and as a doctor he looks in your eye and you know what he thinks, that you are probably the worst doctor he has ever had, because the day before you told him that he's fine. But that's the reality, so we don't have any tool at our hands where we can tell somebody that he is at risk. So what the situation that we have more or less is that a lot of us have unstable plaques, and so we walk around with a ticking bomb in us. We don't know when it goes off and where it goes off. And this is one of the major things that we look at the Baker, and there is clearly a need that we have to develop imaging technologies that allow detection of unstable plaques, and that we develop drugs that allow plaque stabilization. And I just want to show you a few things that we do at the Baker to work in this direction. So we developed a mouse model of plaque instability. Until recently, there was no model available where we could study drugs, for example, or imaging technologies, and we developed this here at the Baker. We work a lot on the understanding how these plaques become unstable. We develop drugs to stabilize these plaques. We develop novel CT technologies to image these plaques, magnetic resonance technologies, and also catheters to identify these unstable plaques. And just a few pictures for that. So this is a plaque, how it looks like in a human, an unstable plaque. And this is how it looks like in a mouse. So you couldn't really tell. And this is the model that we developed. So we now have really a tool where we have a mouse that has unstable atherosclerosis, and we can check whether drugs work on these mice, and then if they work, we can transfer it into humans. This is another example. We developed beads that recognize dangerous plaques. And this is a carotid artery plaque of a patient who had a stroke. And you can show in the magnetic resonance imaging that this really shows up in this plaque. So it's a nice technology that we hope to use in patients pretty soon. And this is the field that Professor Marwick works on, the CT.
And this is one of these coronary arteries, and you can see it lights up here, and this shows you there's a lot of calcium, a lot of necrosis deposited there, and we are trying to develop schemes to say, oh, this is a dangerous plaque and this is a stable plaque. So these are various directions that we pursue at the Baker to work on this issue that we can't identify unstable plaques so far. Now going back to the heart attack. So you would think a heart attack is something that is clear since hundreds of years, and when you look back in history, it has actually been described very early on, similar to atherosclerosis. The Egyptians obviously had heart attacks, and they described chest tightness, and we use the term angina, which says nothing else than the tightness, the Latin word for this, and they described this in their documents, and it's explained as a kind of nerve inflammation with a blood pressure drop. So they didn't really realize what the problem was, but they described the symptoms very well. And what they did as well, they described, or they knew the bad outcome and the recommendation. There is a physician's training booklet still that we can read, and it says if a patient has angina, as a physician, better run away because you can't help him and the family will blame you afterwards. So that was the recommendation. And so they recognized the consequence of the heart attack at least. And then it was in 1910 when two Russians for the first time thought, oh, a heart attack, that's probably something that is caused by a blockage, by a thrombus in the coronary artery. And at that time, Russian scientists were not well regarded in the world, so nobody really listened to that. And 2 years later, an American picked up on the same idea or developed it independently. It's not really clear, and he presented this on conferences, and you can see here, I read it and I fell flat as a pancake. No one discussed it. I was sunk in disappointment because nobody believed that a heart attack is actually caused by a blockage of a coronary artery. And even in the 70s, pathologists at the NIH in the US still questioned this cause, because when they did an autopsy, the thrombus was gone because it was already dissolved. So it was not clear that it's a thrombus, a clot in the coronary arteries. And it was only in the 80s when we developed technologies where we could really go into the coronary arteries and visualize the clot, when people accepted this as a theory that we have a thrombosis, which is the cause of a heart attack. Now, when you look at the heart attack, you have to clearly define how do the symptoms look like. And I think that's very important as patients, as general population, to have an idea of how does a heart attack feel like, when is it a serious problem. So it normally goes along with chest pressure, tightness and pain. And the location of this is shown here. It's typically localized centrally in the chest. It can radiate to both arms, typically more to the left arm than to the right arm. It can radiate to the abdomen, can radiate to the back, and also to the lower jaw. And this is the reason why some patients go to the dentist, because they think they have tooth problems. And so it's quite variable. And the reason for this funny pain location is that the nerves in the heart, throughout evolution, have been reduced. So we have the same nerves that show pain in the arm or in the lower jaw. So the brain can't discriminate whether the pain comes from the heart or whether it comes from the lower jaw. That's the reason why the pain is so funny. It's not only localized at the heart. So shortness of breath is typically associated with heart attack, sweating, sense of doom or fear of death. And a lot of patients, when you speak to them, they tell you they immediately realize there's something serious, and they are really scared that they might die. So some patients, and that's the problem for us very often, just feel a little bit of lightheadedness or dizziness, a little bit of nausea or vomiting, and sometimes very unexplained feelings of fatigue or not feeling well. So the rule number one when you have these kind of symptoms is really to let someone know who is next to you, to your partner, to see a medical professional if possible, and if you really have a strong feeling of chest pain, you should not wait and too long and call the 000. Now, in very often when you look at how heart attacks are manifested, unfortunately it's a cardiac arrest. So very often that's the first sign of atherosclerosis in patients. And for that reason, it's very important that everybody knows how to do CPR, is well trained how to do CPR, and you're probably all familiar with these training schemes that we changed this a little bit over the last years. Now the compression is very much in the focus, and then the airways is the second line of focus. But this is very important that most people really know how to do CPR because it's really a matter of time. If you think about if you have a cardiac arrest, within 2 or 3 minutes without circulation, the brain cells start dying, and you might even recover, and that's what we often see in the hospital, that we recover the heart function because we are quite good in the cath lab, but just having 5 or 10 minutes without circulation in the brain is enough that patients don't wake up anymore, and then we have solved the heart problem, but the brain is pretty much gone. So this is one of the advancements that we have with these automated external defibrillators. So more and more places, public places, have these. It's very easy to deal with them, and they give you instructions how to defibrillate patients when they have cardiac arrest, and there's also an instruction how to do chest compression. So how do we diagnose a heart attack in the hospital? Now, the first one is the ECG. And so this is an advertisement from 1911, just showing how small and how compact their ECG is from this company. So you can imagine when you compare to nowadays, we have ECGs that are the size of a credit card. The technology is around for quite a while. So since the 20s, we realized how a heart attack looks like in the ECG. And we look at these so-called ST elevations, so typical signs in the ECG. So this is a sign here, for example, it's an anterior infarct, this is an inferior infarct. So with these so-called ST elevations, we can diagnose heart attacks in around 1/3 of all cases. So 2/3 don't have any changes in the ECG. So you can't really rely 100% on the ECG. Then we have blood tests, the troponins, but they take a while to be positive. So when you come in the hospital with typical chest pain, we take blood, but we don't wait for the outcome normally. Now, this is the cardiac catheter laboratory, and this is really the big development over the last decades that we kind of witnessed, and I just wanted to give you a bit of a history how that develops. It's actually very much associated with the personal history of Werner Forssmann. He was a German assistant in Berlin in the 20s, and he had this idea to use plastic catheter to push that into the heart and measure the heart, and this is actually his X-ray, and you can see here the catheter comes from the arm, goes down there and down here to the heart. So he had to convince a nurse actually with a cake that she helps him, because he wasn't really, this technology wasn't very well received at the hospital, and he wanted to become a professor in the German system. And this was the assessment that he got from Ferdinand Sauerbruch. He never made it to professor because that was his command. And he later on decided, because he loved to work with these catheters, to become a neurologist. And so he, in the 50s, actually, people recognized how important this development was, and he got the Nobel Prize, but he was still working as a GP because he never made it in the academic system. Another person who kind of drove the development in this area is Andreas Grünzig. He is someone who grew up in East Germany. He, after the wall came up in the 60s, he was one of the people who managed to flee the country through a really risky procedure. He went to school in Heidelberg, studied in Heidelberg, and then went to Switzerland. And on his own, more or less in his kitchen, together with his wife, he developed these balloon catheters. And in 1977, he was the first one who did this balloon angioplasty in a patient. And then he became very famous. And again, he wanted to become a professor in Germany. He applied in Tübingen at several places. And the surgeons realized, oh, this is really dangerous. We don't want to have this guy because we want to do bypass surgery. We don't want to do angioplasty. And so he never got a position in Germany. But in the US, they were a bit clever. They built him a whole institute in Atlanta. And he built a whole hundreds of people he trained in angioplasty until he got a bit kind of over the top. So he thought he can do everything. He got a license for an airplane, a very risky airplane, and he finally, even in a storm, he decided to start, and he crashed, and after, in 85, I think, he passed away. But he's certainly the person, so Forsman and Andreas Grünzig, the two of them kind of developed the technologies that we use nowadays in the cath lab. So then in the US, they used this technology the first time for infarcts, and in Germany and France, they were the first time in 86, so not long ago, when stents were used in patients. Now this is how a stent looks like. So this is on the balloon, and that's the stent itself, and then after inflation of the balloon, then you see that this chicken wire expands more or less, and that's what stays in the coronary artery. And this is now one example of a patient that I did a while ago. So this is the catheter, the plastic catheter, that is pushed from the groin or from the arm, and we inject contrast here, and you can see this is normally where the coronary artery should run, and there's a big clot sitting there. You just see a little bit of contrast going through. So this is the plaque that has ruptured, and where we now have a big clot on top of it. And then we advance a wire through that, and you can see already the wire opens up a part of this blockage, and there's a filling of the rest of the coronary artery. And this is the balloon inflated. This is the outcome. So the stent, so you still see the wire down there. The stent sits here, and so it looks like a native vessel without any problem. And if you achieve this within an hour or two after the blockage occurs, then the whole area here is kind of salvaged. You wouldn't have any scar afterwards. So a while ago we did a film for the TV in Germany before I came here to Australia. I'll just show you this example. This was shown on the evening news. Demonstrating the treatment of a patient with a myocardial infarction. So the patient was brought by a helicopter, and you can see based on the medication, he still had a little bit of chest pain, but he was doing quite well. And throughout all of these procedures, and I think Sue and Sherka will tell you later on, patients are conscious. We speak to them, and we discuss the procedure. And in this case, we actually spoke to the surgeon as well, who shows up here, and we discuss which is the best approach. And this is the sheath that we use. So this goes into the artery, and that's the puncture in the groin in this case. So you have to hit the artery, and then the blood comes out. And this is a wire that goes into the artery, and we use the sheath that goes over the wire, and then the catheters. The catheters will be pushed. So this is the catheter which will be pushed in there. And you see the two X-ray machines and the screens. And this is the angiogram. And in a moment it will show you, this is the right coronary artery, again blocked. You can see the thrombus sitting there. And this is part of the discussions that we had with the surgeons. And then, so this is it will show you the procedure itself. So this is the wire, again introduced there. You see it opens up a little bit, the balloon. And this is how it looks like when you inflate the stent on the balloon. And that's how and then you deflate the balloon, and the stent stays in the coronary artery. So that it's even hard to see here. So what we prefer nowadays when a patient has a heart attack, that we bring him immediately to the cath lab and do this procedure. But Australia is quite, we have a lot of remote places. When you have a heart attack in Mildura, for example, it takes hours to come here to Melbourne. So we can't wait for this. We have to open a blocked artery right away, and for that reason we use so-called clot-busting drugs or thrombolytic drugs. And as you can see here, in some cases, around 60%, they are able to lyse the clots. The big problem that we face with this approach is that we often have cerebral bleeding. So these are very aggressive drugs. And when you have a result like this, where you have a massive bleeding in the brain and you have a stroke, and in this case the patient didn't survive, so you think twice about whether you use these drugs. And one of the directions that we do in our research here is actually develop medication, clot-busting drugs that are effective, but they would prevent this kind of bleeding problem. So what happens after a heart attack? How can we prevent a second heart attack? One of the technologies that we use, and just to show you, are the bypass operations. What we do here, we take veins, or we kind of use arteries, internal arteries, and saw them on the coronary arteries and use them as bypasses. So that's a typical procedure that we do quite often at the Alfred. Now, how does it look with lifestyle change? And I think Sue and Sherkar will comment on this. It's clear that you shouldn't smoke anymore, that you should reduce cholesterol, control your blood pressure, diabetes, be active. That is quite an important part. So we have rehab programs to achieve this, reduce weight, and also have a healthy diet as shown here. Now, in terms of medication, just a few words. Typically, you go home with a cocktail of 5 drugs. Statins are part of it, beta blockers. The statins reduce cholesterol. Then we have drugs that kind of reduce the blood pressure as well. All of these drugs are kind of preventative drugs, so they reduce the risk of having a second heart attack. So that's quite important. The last 2 are drugs that prevent, that stents that we implant kind of clog again and block off the vessel. So when we see these situations after the heart attack, we have to look a bit and give a perspective what we actually try to do at the Baker in this regard. And the 2 areas where we work on really is to develop these clot-busting drugs that wouldn't cause bleeding complications, and also to develop plaque-stabilizing drugs that would prevent having a heart attack instead of treating a heart attack. And now I would like to come to introduce our special guests. So Sue and Shekhar were patients in the Alfred Hospital that I treated a while ago, so they might not have a good recollection of me, and especially in that specific situation, quite a mixed memory of the event. But they probably were kind enough to come here and to explain a bit how they felt the heart attack, how they experienced the procedure, and how they changed their lifestyles. Would you like to start, Sue? So would you mind telling how the heart attack showed up in your case?
Yes, I felt dizzy. Well, with the first heart attack 3 years ago, I felt intense chest pain, and I felt as though I was going to pass out.
So
with the second one,
yeah.
I felt quite dizzy, and then chest pain.
So was it immediately clear for you that you had a heart attack, or how did you experience that?
Well, with the first one, I had an idea, but I was very close to my GP's clinic and was able to get assistance immediately. But with the second one, I just felt dizzy really, and then eventually the pain and heaviness of the chest started, and my husband then called an ambulance.
Mm-hmm. And how did you experience the hospital treatment then?
Well, in both cases I had a stent inserted, and the time that you did it, which was the second one, went through the arm, and that was for me less invasive. We were actually communicating while you were doing it, and I was out of hospital the following day.
Yeah. So would you like to comment a bit how did you change your lifestyle, or what
Well,
did you?
yes, I am an insulin-dependent diabetic, and I have now consulted with my diabetic specialist, and I test my blood daily. I inject twice a day insulin, and I've also made healthier choices in my diet, as well as incorporating daily walks. So yes, I have taken control of that.
So you really take care of all these points that I mentioned before.
Yes.
Yeah, that's quite important.
Yeah.
Thanks very much. Shaker, you want to comment?
Hello, everyone.
Hello.
My name is Shaker, and I had this thing about. Shall I come there?
Sure. Yeah.
I had about 8 years back, and first thing I discovered that time that I had a heart. That major dystrophy. I didn't know that, you know. And then the second thing I discovered other people have a heart. And thirdly is the value of heart. After saying, I didn't know that. When I came, he was the first one. Started with simple sweating, a lot of sweating, and I thought there was something wrong there. And then I decided what to do. And I didn't that time knew that heart attack and you had to dial 000, 000. I thought I'd just walk out, and I wasn't far from the Cromwell Road, which is South Yarra. So I just took a walk outside and thought I'd take a taxi to Alfred, you know. And then decided a neighbor was luckily coming out of the house and said, "Can you drop me to Alfred?" And said, "What happened?" So I said, "I'm not feeling well. It seems like heart, something to do with the heart." So he dropped me, and I saw Karl, and he said, you got a heart attack or something. I said, "Yeah." And he said, "I want to take you in." I said, "Hold on a second, what you taking me in for?" And where you I said, "He want to put some operation." I said, "I better check with my partner who was in Sydney." Remember that? Mm-hmm. And he said, "Why you want to check, you got a heart attack?" I said, No, I never done anything without asking my partner. So anyway, he said, we finally went along, and he contacted. It's all okayed by her, and we went along, and he did the job. And I had no idea of stent, so it was all okay. I knew that I trusted him. with German background, so it should be all right, you know. So that's the whole thing. And the best thing happened after that is that for me it was rehab, the coffee rehab, which was the best thing one could do. Because those days, you know, that coffee rehab must be there still. There's a whole lot of group of people with heart people coming in, and they all were sitting in a sort of area, and they're all looking solemn and, you know, problem. And you know that they're just recovering from 3 days to 6 days to, you know, and they all sitting there waiting for this nurse to come. And we were asked first thing to pick up a small pillow, sort of a sandbag, 1 kilo. And this, you can imagine that you know, about 10, 15 of us picking 1 kilo of sandbag, moving from one table to another table. These are all grown-up people, and moving from there and bringing it back. And I was wondering why they're all doing that, you know? And this is like, you know, you move into a room, these people are doing, and finally, after about 6 weeks, we could pick up about 10 kilos of sandbag moving. So that was the best thing happened, the rehab part. But I had no problem with the diet because my probably heart was all Indian eating of samosas. You know, fried food. So that was my plaque. But other than that, I took to recovery side or after. I took to walking quite regularly. Every day I walk, and now I walk with 95-year-old. I'm 72. And he walks faster than me. And to keep up with him is a big job. And the other day I asked him, how did you manage to be so healthy? He said he was told by someone, longer you stand, longer you live. So whenever I go to his place, he's standing, he offers me a chair. I said, what you want me to do? Die before you? So I said, I'll be with you. I want you to walk with me when I'm 90. He just thought about it, you know, what would happen. He would be 112. I think he will make it. No problem with that. He was good. But other day he said to me that he exercised. I said, what you do? He said he does 20 push-ups just before going to sleep. And I tried to do 5.
Thanks to both of you. I think the important part is really the exercise and the positive attitude after a heart attack. So that's really an important part of getting over the problem and preventing that there is a second heart attack, hopefully.
Well, thanks, Karlheinz. I think we ought to thank both Karlheinz and